Now, we're going to move on to our second big theme, which is about health inequalities. Look at the issue of equity. As with our earlier keynote, we gave you some voices on authors who've been working on this, academics who've been working on this area. And let's hear a little bit from them before our keynote, which is from René Loewenson, who's based in Zimbabwe and runs TASK, which works with health professionals, civil servant and government officials across Southern Africa, especially focusing on this key issue of equity.
China made a big progress in maternal health, but women from the lowest income group, those from very remote area, and the rural to urban migrant are still very disadvantaged in maternal health. Maternal health inequity in China continues to be a big policy issue.
Our research shows that in Africa, health is heavily influenced by migration, water and sanitation, and food security. Researchers and policymakers need to work strongly across sectors in order to address social determinants of health. In response, we have developed a training program that uses a mix of interpersonal interactions as well as the internet.
Our review confirms that the wide gap in equity in access to maternal health care services in India is due to economic status, gender norms, social status, education, and age. Because of the diversity of the country, state-level equity analyses are needed so that disadvantaged populations can be identified and targeted with appropriate interventions.
Incomplete analysis of equity can actually contribute to disadvantage and exclusion. We can generate better accounts of this key public health concept in two ways: through attention to structural root causes, to the political ideologies that underpin public policy, and secondly, through enabling critical perspectives of those for whom these issues are most directly relevant.
Good afternoon. Well, we live in interesting times, don't we? And I think from the deliberations that we've heard so far, we've had very, very interesting ideas put across. I'm aware of the fact that as we think about these Millennium Goals, we're thinking about stretching to 2030, I think I've heard said, and that we're sandwiching ourselves in between very immediate targets that are being put across to us of financial and fiscal imperatives, debt, taxes, public sector funding austerities, etc., and very long-term targets around environmental, some of them I've seen stretching to 2100. And one of the concerns is the immediate going to subjugate the medium and the long term? Are the immediate economic targets going to subjugate the medium-term social and the longer-term environmental? And what consistency is there between these economic, social, and environmental targets and goals and so on? And why is this important for inequality? Well, the reason I'm raising this is because it is only a values base that's going to allow us to achieve that consistency and coherence across these different areas. And that as far as I'm concerned, equity and solidarity has to be a significant part of that values base that allows us to achieve that. So in order to look at that, I'd like to take us back to not the goals, but the Millennium Declaration, because from my perspective, that sets the political intentions that the heads of states made in 2000 that set up the Millennium Development Goals. And if you look at that political Millennium Declaration, you will see some terms there which are very important for addressing inequality. For example, they talked about globalization becoming a positive force for the world's people. They talked about fundamental values underlying whatever we do in dealing with our way ahead. They talked about respect for rule of law, but they talked even more deeply about rights to development, not just political rights, but social and economic rights. And they talked about solidarity, support to Africa. Solidarity not only in terms of aid, but in terms of transfer of technology, in terms of trade and debt and so on, at a much deeper economic level. So what do these sorts of statements imply for inequality? Well, they talk about inequalities as a measure of the violation of rights. Here you get a connect between justice and rights. That where we don't deliver, where we do find inequalities, we have a violation of the right to health, but also of a violation of the rights to the determinants of health, and I'll come back to it. These determinants lie in things that we know very well, water, food, etc., as well as the deeper determinants of the systems and markets that deliver these essential needs. Fundamental values of equity and solidarity speak to questions of injustice in the gap between the resources for health and the delivery of those resources to those who need them most. Globalization becoming a positive force is about the inequality between the opportunities of the technologies, materials, goods and services that we have, and the access to those technologies and innovations that we have for health. And then finally, the shared responsibility framework of countries globally towards addressing issues of health refers to inequalities that are generated through competitive relations rather than relations of solidarity. So it is to these sorts of issues that I'd like to reflect when I talk about inequalities. And I'm going to draw on a body of work that we have been implementing for a long time in Equinet, a regional network on equity and health in East and Southern Africa, which has been tracking inequalities in health at regional level as well as within countries. And all of this work is on our website, and I brought a couple of copies of our latest Equity Watch for those who are interested. So let me reflect from that experience. Well, when we look at this MDGs, and I've been reading the reports, you find massive success, and I think we can celebrate success. For example, in relation to violations of rights, the statement is very correct that we're making significant progress in the MDG on the target of having access to safe water, one of the most fundamental rights to health, in health. And certainly that's a cause for celebration. But when you start looking across countries, you find that a region such as my region, Africa, that progress has not been quite so profound. That it has in fact been a bit slower than globally, and we are nowhere near delivering on that target as the aggregate shows. Further, as you start disaggregating the populations within countries, you find that for the poorest wealth quintiles that are shown at the lower end of the graphs, the closer to the vertical axis on these charts, in urban areas in the first chart and rural areas in the second chart, the gap is even wider, where you're finding up to, in rural areas, 66% of the poorest quintiles having access to safe water. What does this actually mean? Well, it means that we have 386 million Africans, if you apply the populations in those quintiles to the percentages that don't access, 386 million Africans that do not access a basic right to safe water. In a context where we are busy celebrating the delivery on the Millennium Development Goal. The same sort of information we can find for a number of the other development goals, whether we are talking about survival or whether we are talking about malnutrition, and this is documented in our publications. I don't really have the time to go into depth, but if you look at the chart on the bottom, for example, in relation to chronic stunting in children under 5, you find the gap between the poorest and the worst performing and the highest performing region, even in the same country, to be significant, gaps of the range of about 60 to 70 percentage points in the level of chronic malnutrition. And when you start comparing countries in Africa to the rest of the world, such as to Europe, gaps are even wider of 25-fold. So the question that we're asking, is this acceptable? And one of the points is that, okay, well, these kind of gaps will be closed as we improve, as we improve towards the aggregate. The problem is, I think, as somebody has mentioned earlier, that they don't close. In some countries, and this compares the demographic and health surveys, at 2 different points in the post-2000 period, after the Millennium Goals were set, improving the aggregate, improving child survival, went along with widening the inequalities between different wealth groups. So we actually improved the aggregate, but increased the gap between the richest and the poorest. So it's not just improving the aggregate, it's actually how we do it that makes a difference. so that the lower, more disadvantaged groups do not fall behind in the process of trying to reach a target. So it brings me back to this question of violations. All of our countries have signed on to the International Covenant on Economic and Social Rights. All of our countries have said that states, parties, have an obligation to the right of everyone to the attainment of the highest standard achievable of health. What is the highest attainable standard of health that we are saying we've committed to? Is it closing the gap within a country between the lowest performing and the highest performing wealth group? Surely all of us in one country should have the right to whatever that country can deliver for its wealthiest community or for its best performing region. So surely closing the gap must be what that international covenant referred to. What about globally? Is it acceptable to have a 25-fold difference in child survival? Was that the intention of the International Covenant on Economic and Social Rights? What gap are we going to close? So my first point about this post-MDG process is that aggregates are not sufficient, and we must measure the gap, and we must aim to close it. As the second dimension of injustice, of resources reaching those with greatest need, is evident when you look at the delivery of health services. Health services are one of our most critical ways of closing the gap. And yet we see wide inequalities in access to the most basic things, like access to maternal health assisted deliveries. Sometimes again, 60 to 70% difference between different wealth groups. We don't find these kind of inequalities as great in child health. So what's going on when we come to an issue like maternal health? Or for that matter, access to antiretrovirals, or for that matter, access to insulin for diabetics, or a lot of the NCD innovations that we talk about. And what we found is hinted at in the photograph taken from one of our community photographers from Uganda, is that the minute people have to move outside their community to access a service, in this case have to go to a district hospital or a higher level service, the inequalities grow. So we've also found, and if you look at the graph on the bottom, that the poorest groups have the greatest benefit from services that are provided within the community, close to communities. In other words, the community and primary care services. If you look at the graph on improving access to prevention of maternal to child transmission in Mozambique over the years, the final bar is the bar when Mozambique was able to put those services at their primary care level. And it shot up in terms of overall coverage, but also in terms of coverage of the poorest groups. So we know that we can do better when we bring services to primary care level. So perhaps as we talk about universal health coverage, we should be saying that we have a global public responsibility to ensure that whatever innovation we're talking about, cervical cancer vaccination, antiretrovirals, whatever, should reach the community and primary care level of the health system. And that in fact, those primary care facilities are a global responsibility. We have to track and make sure that we deliver whatever innovations we have at that level, because that's not currently happening. The gap between opportunity and practice. Well, let me come back to this issue of safe water. It's one of the most important innovations for health that we've made in the last 150 years. I remember Peter Piot saying, well, if antiretrovirals was just water, still a half of the world's population wouldn't access them. So the question is, why do we have this level of massive inaccess to something that we've known about for such a long time? Why is it that we cannot even deliver technologies that the Romans had the benefit of 2,000 years ago? What does this imply for health beyond 2015? Well, it's not availability. We've known these technologies. It isn't actually the capacity to deliver and implement. Because in Uganda, for example, we were able to see massive improvements in access to safe water when community actors were brought together with state institutions and resources to implement safe water. The same for sanitation. There is something about the way our public policies and markets are addressing the delivery of resources that means that things as fundamental as safe water are not reaching people. Remember, and keep this figure in mind, it costs $10 billion annually to deliver safe water to the global population. $10 billion annually to deliver safe water. We put through in our currency exchange markets $3 trillion every single day, not every year, every day. That's 3,000 times the amount we need to deliver safe water annually to the global population. Something weird is going on in relation to our Millennium Promises. The same applies with respect to food and nutrition, for example. In our studies, we've consistently found that, that communities with high level of malnutrition live inside or right next to areas of food surpluses. In this case, Tanzania, child stunting being highest in the areas of greatest food surpluses. So it isn't only about the practices of the people in those areas, it's something about the market systems, which are very efficient at extracting resources from those in need, but very poor at delivering them back to those in need. This becomes a very difficult phenomenon for us globally when we start talking about the level of urbanization that we are going to experience in the next 20, 30 years, where people are going to be living in increasingly close proximity of great poverty next to great wealth. Here, for example, Luanda's informal settlement, right next to a bustling, growing commercial business district with lots of signs of construction and expansion taking place. Or where people in Cape Town, one of the wealthiest cities in our continent, sit in extremely long queues waiting for a primary care clinic to serve them, having just passed a rather rich private service in the neighboring neighborhood, which has got no evidence of any overuse whatsoever and probably captures a significant more resources. Is this a recipe for global security? I heard about the military being talked about. Can you have security in an environment where you have this level of inequality? We're beginning to see activism growing around this kind of inequality in North Africa and in other parts of the world. And it's certainly a domain that we need to think about very seriously. So unless we take on social cohesion, fair benefit, and public interest in the way our resources are flowing within markets and within our public policies, we are actually opening ourselves up for a significant level of insecurity. So it brings me to the final point, which is the determinants of global inequalities and global solidarity. Well, the Globalization Knowledge Network in the Commission on the Social Determinants of Health put together an impressive body of evidence about the social determinants of global health inequality. And interestingly, what they came up with was that we did not achieve the life expectancy gains that we should have expected to achieve under globalization because of a number of factors. And they included in that factors of income inequality, economic volatility and crises, capital outflows and plateauing primary health care. Now, this is something that I feel rather passionately about in our region, because we tend to talk about donors coming to our region and bringing us funds. But to be honest, more funds are flowing out of our region and out of the global south than are flowing into the global south. Actually, by the time of the global financial crisis, developing countries were transferring about $1 trillion back to the global high-income countries than they were receiving back in foreign direct investment. So this is a significant inequity in resource flows and undermines our ability to deliver on things like universal health coverage and so on. This becomes even more important when we look at what's going to happen in the next 30 or 40 years. I'm part of another process which is going on through Rockefeller of looking at global health in the next 100 years. And one of the things that struck me is about how much health is going to be a site of wealth creation because of the innovations in biotechnology, gene technology, the links between biotech and information technology, and so on and so forth. The question is that as we are accelerating innovation in the health sector, and it becomes a site of wealth creation, unless we have in place good mechanisms for generating return to those with greatest need, we are going to see increasing and not reducing inequality within the global community. What we've experienced from the commodification and privatization of water, we will begin to experience from the commodification and privatization of genetic material, which is a pretty scary thought in terms of the gap between augmented and non-augmented human beings. And secondly, the kind of climate change things that we heard about this morning will generate resource scarcities in goods like water and so on that will make this increasingly unaffordable unless we take the public goods dimensions of these sorts of areas back again. Is this happening? Well, it's rather worrying when we see that countries respond to the financial crisis the crisis of energy or the crisis of food by grabbing land from African countries to grow food for themselves or to generate biofuels, but not necessarily in a way that protects biodiversity or smallholder farmers that have an important impact on the child health nutrition that we saw earlier. We see a level of business as usual when we hear that there's been 20% growth in wealth in the 1,200 global billionaires since the financial crisis, when there's been a rise in the speculative derivative markets by about 100 trillion in 1 year since the financial crisis. So we actually have to ask ourselves, is the speed with which austerity is being placed on populations the same speed with which the financial markets are being regulated? And the signs don't seem to indicate that. So the question is, how quickly are we putting in place the global instruments for solidarity, for dealing with competition between nations that will allow us to deliver on equity? Are we revisiting our patent systems in a more coherent way? There is discussion within WHO on transfer of technology. Yes, that's very important. There is even a report in the US now that questions whether the patent system has validity because it is actually repressing innovation, which should be as free market in a way as some of the other areas of trade. What mechanisms are we using to deliver on that? Are we bridging the shareholder-stakeholder divide in the corporate sector? Have we made corporates responsible for wider environmental and public interests? And when we look at the wealth flows, if we had put even a 5 cents in every $100 tax on that wealth flow, we would have been able to generate about 8,000 times the need for something like safe water. Significant global resources. So as I move to my final point, what consideration does this imply for global health post-2015? Let me restate some of the points that I want to make. Firstly, the aggregate is simply not enough. We have to track inequalities in health. We have to track inequities in health. And we have to close the gap. We have to set standards that will hold us accountable for closing the gap between those with worst and highest as a matter of the right to the highest attainable standard of health. Interestingly, UNEP has put in place a measure for an ombudsman for intergenerational equity in the environmental scenario of policy. My question is, why don't we have an ombudsman for equity in the UN post-MDG process? Because equity is talked everywhere but delivered nowhere at the moment. We need to break the inverse care law. As health workers and as health professionals and health activists, we need to break the law, but the inverse care law. In other words, we need to explicitly track and monitor that resources flow to those with greatest need within our clamors around universal health coverage, and explicitly ensure that they reach the primary and community level of the health system. It should be important for us, for example, to know whether there is a clinic within 5 kilometers, whether there is a community health worker, whether the clinic has water, whether the clinic has a midwife, whether the clinic has drugs for diabetes, or whether the clinic is able to monitor a school health program to give vaccinations for cervical cancer or pap smears or whatever else it happens to be. Growth is not enough, and I think we've heard this today. We need to ensure that economic performance and markets also serve social well-being and ecological integrity. And here I have 2 questions for our able moderators. One is for Nisha, which is, when are you going to ask the media, in between the section of the main news, the business news, and the weather, to also tell us as a society about planetary health? What are we doing as a society? What progress did we make today in addressing our health and environmental well-being? Because it's media that actually shapes a lot of social attitudes or leaves us in ignorance. And then I'd like to ask Richard, are you going to announce the Lancet Commission on Planetary Health that will allow us to move beyond the diagnostics to the solution space, to look at the laws, incentives, and measures that bring together an equitable convergence between environment and public health, so that we can lever a change in that economic community that we are finding quite difficult to bring on board onto these processes? And then as my last area, global solidarity. We need to build solidarity beyond aid. The Millennium Declaration talked about commitment to solidarity. So can we move towards corporate responsibilities to stakeholders and shareholders? Can we move towards a different system for global innovation to ensure both reward for innovation and access to it? And can we ensure that global funds are taxed, brought into public domain and regulated for social and ecological well-being? That's what I'd like to be monitoring into the years beyond 2015. Thank you very much.